So research to practice, demystifying molecular-based tests in head and neck cancers with Siddharth Sheth, DO, MPH. And whoops, went too far there. So Siddharth Sheth, DO, MPH, is a board-certified medical oncologist and tenure-track assistant professor of medicine with the Division of Medical Oncology with a secondary appointment in the Department of Otolaryngology at the University of North Carolina, Chapel Hill. His clinical expertise in the treatment of head and neck cancers and thyroid treatment of head and neck cancers and thyroid cancers. His research focuses on early phase clinical trials and evaluating promising biomarkers. At UNC, he is a member of our dynamic head and neck cancer research program. He leads multiple clinical trials, many of which are evaluating novel combinations of immunotherapy and targeted therapies. To complement this work, he has developed a keen interest in non-invasive biomarkers, specifically circulating tumor DNA or ctDNA. Dr. Sheth greatly enjoys caring for his HNC and thyroid cancer patients. The multidisciplinary team at UNC is deeply committed to providing the best care and support for its patients. By designing and leading clinical trials and translational studies, Dr. Sheth hopes to positively impact his patients' disease outcomes and their quality of life. Dr. Sheth, welcome. We're really pleased to have you here today.
Thank you so much.
Absolutely. And what's one thing we should know about you outside of that professional bio?
Well, I have a 20-month-old son who runs our life outside of work. So he is and a puppy as well. So
Wow.
they take our time. Yeah.
Wow. And is that your 20-month-old that we get to see a little further on in the presentation?
Absolutely, yes.
Great. We were hoping so. We thought that might be the case. All right, we mentioned poll everywhere. This is just a screenshot of your first question. Which of the following is not a cancer of the head and neck region? We try to make these kind of a softball. I think this one is oral cavity, pharynx, spleen, or salivary glands. And while you are going ahead and responding to that, I will say that this activity has been planned and implemented under the sole supervision of the course director, William A. Wood, MD, MPH, in association with the UNC Office of Continuing Professional Development. The course director and CPD staff have no relevant financial relationships with eligible companies as defined by the ACCME. The University of North Carolina, Chapel Hill is accredited with distinction as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. A potential conflict of interest occurs when an individual has the opportunity to affect educational content about healthcare products or services of a commercial interest with which she has financial relationship. The speakers and planners of this learning activity have not disclosed any relevant financial relationships with commercial interests pertaining to this activity. The presenter has no relevant financial relationships with ineligible companies as defined by the ACCME. All right, Dr. Sheth, seems like one of the answers is emerging as the leader here. How are they doing with spleen?
Yeah, pretty well. So I guess I don't even have to give this talk, but yeah, no, right answer.
Okay. Yeah. Well, I think you've got some harder questions ahead, so we'll let you do the lecture anyway. All right. Really glad to have you here. Demystifying biomarker testing in head and neck cancers. Dr. Sheth, I'll turn it over to you.
All right. Well, thank you so much for the opportunity to talk, and thanks for everyone joining the talk today. So just one quick disclosure. I received research support from Natera, which is a company, and I'll be discussing research that's ongoing with Natera in this talk. And so first, wanted to do a knowledge check and with a clinical case, and we'll be weaving in this clinical case both at the beginning and at the end. And so this is a 58-year-old male who has a former smoking history, 1 pack per day for 30 years. His medical history is significant for well-controlled high blood pressure and diabetes. And in 2020, he was diagnosed with a right tongue cancer that was found to be squamous cell carcinoma, and he was treated with surgery followed by radiation therapy. He represents back to you in July 2022 with 3 months of tongue pain that has progressively worsened. He also notes that he has some new shortness of breath, particularly with exertion. And so you image him with the CT scan of the neck and chest, and you find that he has a 3 centimeter right tongue mass, some new cervical lymph nodes, and multiple pulmonary nodules. And so you diagnose him with recurrent metastatic squamous cell carcinoma of the head and neck. And so the first question is, what test is mandatory to select the optimal standard of care for treatment? Is it P16 HPV status? Is it combined positive score for PD-L1 expression? Is it next generation sequencing and doing DNA sequencing? Is it tumor mutational burden, or is it circulating tumor DNA?
All right, Dr. Sheth, and if you don't mind, go ahead and advance that one slide, and there we go. That'll open that up.
All right, perfect. So kind of see a distribution of different answers. I will not say the correct answer because we're going to revisit this question at the end, but hopefully everyone will have it correct at the end of the talk. So for the same patient, we decided to get all these tests and find out that he is P16 HPV negative. His PD-L1 expression is 25. His tumor mutational burden is low. We do DNA sequencing and find that he has a TP53 mutation. And we also do circulating tumor DNA, and he's found that he's positive for the same TP53 mutation that was found in the tumor. So what is the best treatment option based on the following? And so is it cisplatin with radiation therapy? Is it a TP53 inhibitor? Is it pembrolizumab? Is it nivolumab plus chemotherapy, or is it hospice? And just so everyone knows, pembrolizumab and nivolumab are both immunotherapies targeting the PD-1 pathway. Okay, so again, we'll revisit this question at the end, but a wide range of responses. So here are my objectives for the talk. We'll be talking about the most clinically relevant biomarkers for management of patients with head and neck cancer. Second, we'll be reviewing the role of next generation sequencing and how we use these technologies to select therapies for our patients with head and neck cancer. Third, we'll talk about circulating tumor DNA and how it's being used currently in clinical applications. And finally, we'll spend some time in this research to practice piece of how some of these emerging technologies are being implemented into clinical trials. So I always use this slide as a head and neck cancer primer. So when I think of head and neck cancers, these are a heterogeneous collection of tumors based on anatomic location. The most common locations are the oral cavity, the oropharynx, which includes the base of the tongue and tonsils, and the larynx, which is the voice box. We also have less common sites, which are the paranasal sinuses and the salivary glands. And so when we think of pathology, 95% of head and neck cancers are squamous cell carcinoma. It's really in these paranasal sinuses and salivary glands where we see other pathologies. When I think about staging, so it is complicated, and we use the American Joint Commission of Cancer, the 8th edition, but I like to keep it simple and break it down into early, locally advanced, and metastatic disease. So early stages where you have a small primary tumor, that's about 40%. Locally advanced is where you have either a large primary tumor involving lymph node disease, that's about 50%. And then only about 10% or less of patients present with metastatic disease. And so again, this is an important point because this is an opportunity to cure, or at least try to cure, the vast majority of our patients at presentation. And then treatment, so if they have early stage, we can do single modality treatment with either surgery or radiation therapy. If it's locally advanced, that's where we talk about multimodalities, so either primary surgery followed by postoperative therapy, which usually consists of radiation plus minus chemotherapy, or a non-surgical approach of concurrent chemoradiation therapy. When we have patients with metastatic disease, so coming out of the head and neck region, this is where we talk about using immunotherapies, chemotherapies, targeted therapies, or a combination of these. And finally, in terms of prognosis, we know now that you're having HPV-associated or human papilloma virus-associated tumor, the prognosis tends to be good. And if it's a non-HPV or typically a smoking-related cancer, the prognosis is poor despite our advances in therapies. And we'll be touching upon this later in the talk. And so just to give a small shout out to a talk that I gave 2 years ago for a really kind of a more in-depth clinical review, that not too much has changed, unfortunately, in head and neck cancers in the past 2 years. So you can find this video and get information for, again, a more thorough clinical review. But rather, what I want to focus on is biomarkers and how we use them in head and neck cancer. So what is a biomarker? And this is a definition from the National Cancer Institute website. And so it's a biological molecule found in blood, other fluids, including urine, saliva, pleural fluids. It could be found in the tissue. That's a sign of either an abnormal or normal process of the disease. And relevant to our talk, a molecular biomarker is a DNA or RNA-based biomarker. And so how do we use biomarkers in head and neck cancer? And I think many of you have seen, a pretty schema like this before. And this, unfortunately, is a very simplified understanding of how we use biomarkers. And so in clinical applications in the real world, it is much more extensive and complex. So it's just not as easy as finding a patient, getting a sample, figuring out a biomarker, and then just giving them a therapy based on that biomarker. However, I think it is very critical to understand what are the available biomarkers and how we can use them to give the best treatments for our patients. And hopefully at the end of this talk, you'll feel comfortable not only for head and neck cancers, but these can be applied for other tumors too. And so what type of biomarkers exist and how are they used? So, there are many different forms. Here we see prognostic. I think a better term would be screening, but how likely are you to develop this a cancer? 2 is diagnostic. So can we use a biomarker to identify the type of cancer it is? 3, is it a predictive biomarker? So what is the right drug for helping to treat my cancer? You have pharmacodynamic biomarkers. So how does my body respond to treatment? And so what is the optimal dose or scheduling for it? And then finally, biomarkers that target recurrence. So can we use it to help predict or show that your cancer might be coming back? And I think I really like this picture because what it shows is that there's not a one size fits all for biomarkers. There are many different types. And so one biomarker might be helpful for a subset of patients, while another might be helpful for another subset of patients. So we have yet to find the holy grail of one biomarker that works for everyone. And so what are the biomarkers that are most clinically relevant for head and neck cancers? There are 5 that we'll be touching upon today. So human papillomavirus, PD-L1 expression, next generation sequencing, tumor mutational burden, and circulating tumor DNA. So let's get into it. So HPV or human papillomavirus, as everyone knows, this is a virus that is transmitted either sexually or vertically at time of birth. It's associated with multiple malignancies, including gynecologic cancers, anal cancers, penile cancers, and head and neck cancers. And really until 2020, gynecologic cancers were the most common types of cancers due to HPV, but head and neck cancers have taken over in that time. There are over 200 types that have been classified, and really HPV-16 is the subtype that's most associated with the formation of head and neck squamous cell carcinoma. We think of other high-risk strains that we occasionally see, 18, 31, or 33, but HPV-16 accounts for about 70 to 80%. And this picture is just an example of what a cancer looks like clinically. And here you can see pathologically how it progresses from just extra growth of cells all the way to changing cells to full-blown cancer. And so when we look at guidelines now based on the NCCN, if you have an oropharynx cancer, so consisting of the base of tongue or tonsils, testing for HPV is now mandatory. And so there are many ways that we can test for HPV. You can use P16 immunohistochemistry, you can use HPV in situ hybridization, and you can also use PCR. And so I did want to spend a second on talking about P16 because this is something you might see in the pathology report, and it's important to understand what this is. So P16, to think about HPV, there are really two major signaling pathways. That's E6 and E7. And what these are viral oncogenes. And essentially what E6 does is it can inactivate the tumor suppressor gene P53. And we think of P53 as being this master regulator for DNA damage repair and cell death or apoptosis. And similarly, E7 targets RB, and RB is very important for helping with cell cycle regulation pathways. And so when you have E6 and E7 in overdrive, it can lead to cell dysregulation, it can lead to genomic instability. And basically what that does is leads to this overexpression of E2F, and that increases the cell cycle and then ultimately upregulates P16. And so when we do a biopsy and we test for P16, we now know that it's a very well validated surrogate for HPV status. And so HPV, again, why it's important is that we know it's useful for multiple things, including diagnosis, prognosis, treatment selection, and monitoring. A little bit outside of the scope going into each of these, but when we think about HPV, again, what specimen should we test it on? You can either do it on the primary tumor or a regional lymph node metastases. That's typically the cervical lymph node. And so when should HPV testing, again, consistent with guidelines for any oropharynx primary cancer, so consisting of either the base of tongue or tonsil. And I do want to spend a second talking about the study, so RTOG 1016. This was done, and I'm sorry, it's 0129, and this was done about 2 decades ago. And what this really showed was how we could risk stratify oropharynx cancers based on HPV status and smoking status. And so walking you through this, if you have an HPV positive tumor and a light smoking history, you're classified as low risk. And conversely, if you have an HPV negative tumor and a heavy, more than 10-year pack-year history, you're considered high risk. And what you can see on this Kaplan-Meier curve is that based on your risk, your overall survival at 3 years is very good if you're low risk and dismal if you're poor at high risk. And this, again, is where we see a majority for HPV-associated head and neck cancers. So good prognosis for these patients. So next I want to talk about PD-L1 expression. And so what is PD-L1? It is a protein, and its major function is to keep the immune system under control. And so kind of think of PD-L1 as a brake on your immune system. And so you can find PD-L1 both on normal cells, but also tumor cells. And what PD-L1 does is that it will bind to another protein called PD-1, a protein that's found on your immune cells or your T cells. And it basically keeps the PD-L1 cells from interacting with cancer cells and killing them. And so what these therapies now do, these PD-L1 and PD-1 therapies, is that they can bind to this ligand called PD-L1, and it prevents binding to PD-1, and that allows the immune system to be free and start targeting the cancer cells and helping to shrink the tumor and kill the tumor. So how do we measure PD-L1? It's measured using immunohistochemistry. And there are kind of 2 flavors for how we now measure PD-L1. You can either use TPS, which is your tumor proportion score, or CPS, which is combined positive score. And so depending on what cancer you use, so lung cancer more commonly use TPS, but we know for head and neck cancer that the combined positive score is superior to TPS, and it's better at predicting immunotherapy response. And so there have been studies now that show that CPS is kind of the key, and we now clinically use CPS for the PD-L1 expression for our patients to help determine what treatment to use. And so when should PD-L1 expression be ordered for patients? For any patient now that has recurrent or metastatic disease. And so what is the data for now using immunotherapy? It's really Keynote-48 was the big study that came out in 2019. I don't want to go into too much detail, but I think the major story for this trial was that cetuximab and chemotherapy was the standard of care for a few decades until the study started and the results came out. And so that was used as the control arm. And what the study had two experimental arms using pembrolizumab, which is immunotherapy on its own, or pembrolizumab plus chemotherapy. And what they found in Keynote-48 was that if you had a patient with a CPS score, or PD-L1 expression score that was higher than 20, you achieved a survival benefit with pembrolizumab alone compared to cetuximab and chemotherapy. And similarly, if you had any CPS score, so 0 or greater, the combination of pembro plus chemo was superior to cetuximab and chemotherapy. And so what this data showed and led to eventually was the FDA approval of immunotherapy in the first-line recurrent metastatic setting. What we also found and what we know is that immunotherapy is very well tolerated, and so it has an overall better safety side effect profile compared to chemotherapy. And so next, the third biomarker we'll talk about is next generation sequencing. And so really what NGS is it's looking at taking a piece of the tumor, extracting the DNA, and then having this bioinformatics platform where we're able to look at what the DNA makeup is of a tumor and see what are the changes or alterations that are specific to a cancer. And so there are many different types of panels that can be used for DNA sequencing. You can use whole exome sequencing, so looking at the whole exome. You can use targeted panels that look at a smaller number of genes. You can also do, in addition to RNA or DNA, you can look at RNA. And then finally, for certain inheritable disorders, you can do germline testing, so looking at normal cells, not tumor cells. And at UNC and at Chapel Hill, we, for head and neck, we've been using a specific company called Tempus that uses a targeted panel of 650 genes. And so, again, for NGS, what laboratory should you use? There are many good companies out there. I would say the two biggest ones are Tempus and Foundation Medicine. But their, academic centers have their own panels that have been used. UNC has had something in the past. And so, I think it's less about which panel is the best. I think they all have very good platforms. It's really about getting the information from the panel that is the most important. So here, what I wanted to show you is when you use one of these companies, what they'll do is come back with a patient panel and show you all the information associated. So this is a patient with lung cancer, and what you can see is that there were 2 mutations that were identified. And then they give you information about what are the potential treatments that you can use. They'll tell you if it's FDA approved in that specific tumor. And they'll also tell you what clinical trials are currently available. So these are really powerful reports to help your patients determine if there's, other alternative therapies for them. And so what I wanted to show you here was, again, a Tempus report. And so Tempus will not only show DNA sequencing, which I mentioned, but it will also do the PD-L1 expression. So this was a patient of mine where they took a piece of the tumor, removed the DNA, and they showed that the CPS score was 1 for this patient. So their PD-L1 expression was positive. Here was the same patient where they looked at the DNA sequencing and showed that there were 3 major genomic variants that were identified, with PIK3CA being the most important. And so why being the most important? Because it's potentially actionable. So what that means is that we have a drug that we could potentially use to target this mutation. What these panels will also show you is tumor mutational burden, which I'm going to talk about and what this means, and then also microsatellite instability status, which is less relevant for head and neck cancer, but important for other cancers like colorectal cancer. And as I alluded to, so for that same patient, we found a PIK3CA mutation. It was a gain of function mutation. And so what the report said is that you could consider using alpelisib, which is an inhibitor of this pathway. And it also identified that there are ongoing clinical trials that not at UNC, but at other centers that we could potentially consider for our patients if you wanted to put them on trial. And then finally, Tempest and other panels can show RNA expression. So here we had a patient that did not have any alterations found in their DNA, but we found that they had overexpression of retin androgen receptors, so potentially those could be targets. And then finally, this was a patient of mine that has a really rare cancer called a nut carcinoma. And so we could use Tempest to not only identify this fusion, RNA fusion, but that helps with not only diagnosis of that cancer, but also with treatment options. So finally, about NGS, when should we be using it? It can really help with treatment and diagnosis, particularly for rarer cancers, but I don't order it for all my patients. I think there are very good standard of care options that we could consider before we need to reach for next generation sequencing. So my advice for when to order NGS is either for rare tumors, and that could be at any point, or specifically for head and neck squamous cell carcinoma, doing in patients with advanced disease. So after they've progressed from first line recurrent metastatic, that's when it could be very helpful. So next I want to talk about tumor mutational burden. So what is TMB? So it is a calculation that looks at the number of clonal mutations in a cancer and divided by megabase. And so why TMB matters is because the higher the TMB, the more likely you are to develop neoantigens. And so with more neoantigens, the thought is that you're more likely to have a response to immunotherapy. And they've done multiple studies to show what constitutes a high TMB. And so now 10 mutations per megabase is considered the cutoff of being TMB high. And there's now good data to show that having a high TMB, you're more likely to respond to immune checkpoint inhibitor. And so how do you order TMB? Again, you have to use, it's a tissue-based test, most commonly in using next generation sequencing, so DNA sequencing to identify. And you need to have really a large panel, at least 100 or more genes to have a decent number to have a reliable TMB result. And so what is the data to support TMB? This is a study, Keynote 158, and so this was done in 10 rare cancers. And what it did was compare patients that had either low TMB in light blue or high TMB in dark blue. And what you can see is that patients with higher TMB were much more likely to respond to immune checkpoint. In this study, they received Keytruda or pembrolizumab. And so the patients with the high TMB had a 30% response rate to pembrolizumab versus only about 5% to low TMB. And so what this led to was an FDA approval of pembrolizumab for patients with TMB high tumors. And for one of the first times, it was a biomarker that's tumor agnostic. So it doesn't matter what type of cancer you have, it's really just looking at the tumor mutational burden status. And I think one important point to make, and not to get too much into the detail, is that the FDA approval was really based on response rate, not overall survival. And going into that, you can see on this image on the left here, when you have a high TMB, it looks like your overall survival status would be better compared to patients that have low TMB. But the study, what it did was further substratify patients by their DNA damage repair status. So there's multiple proteins, POL-D, POL-E, mismatch repair deficiency. And what it showed was that maybe the response to immunotherapy could be driven by this DNA damage statuses and not the TMB status. So there's, I think, just more that we have to learn about TMB and really how to use it most effectively. But the takeaway points are that not all TMB high tumors are going to respond in the same way to immune checkpoint inhibitors. And there's now good data to show that cancers that have environmental carcinogen exposure, so whether that's UV radiation for something like melanoma or tobacco for head, neck, and lung cancers, they're going to be more likely to respond to immune checkpoint inhibitor. And so finally, when should you order TMB for your head and neck patients? I would say you shouldn't order TMB just to have it. And the reason for that is now for that Keynote 48 data that we showed, immunotherapy, specifically pembrolizumab, is standard of care. And so patients are going to be receiving immunotherapy regardless of their TMB status. And so it's not necessarily providing additional helpful information that for patients that you're seeing in the clinic. And so when should you consider ordering TMB? I really think it could be helpful for other head and neck cancers, so your rare cancers like your salivary gland cancers, perhaps your sinonasal cancers, your thyroid cancers. It's there where you're looking to potentially incorporate immunotherapy, and insurance companies might look for TMB status and a high status to then approve the use of immunotherapy for those patients. And so, is there anything else to know about TMB? Yeah, and I'll just touch upon is that there are now efforts to measure TMB within the blood. And so this was a study that was done in lung cancer. And, I don't want to spend too much time on it, but basically what they did was they were able to measure TMB again in the plasma, and they used different cutoffs to determine what TMB high versus low would be. In this study, they ultimately used 16 as the cutoff. And I guess the major takeaway from this study is that there's not perfect concordance with blood-based TMB and tumor-based TMB. And so my takeaway, at least for 2020, is that blood-based TMB is still an exploratory biomarker, and there's no utility for ordering it for routine clinical care. This might change in the future, particularly as we're getting better with sequencing plasma, but for now, I wouldn't recommend it. And so finally, the fifth biomarker that I wanted to discuss was circulating tumor DNA, or ctDNA. So what is ctDNA? It's basically cancer cell DNA fragments that enter the bloodstream after a tumor dies. And so this can be now measured in the plasma. I think one thing to note about ctDNA, it's not only in the blood or plasma where we can measure it. There are many different analytes. You can use urine. People are looking at saliva. They're looking in pleural fluid. And so, again, when should ctDNA be ordered? It is definitely not standard of care for head and neck cancer. For other malignancies, it's now becoming integrated into clinical care. But I would say that there is definitely a growing consensus for using ctDNA for virus-based cancers, particularly HPV and also an EBV-associated or Epstein-Barr virus cancers. And so I did want to touch upon ctHPV DNA. And so we've done a lot of work at UNC, but this is a huge effort internationally too. And so there are two ways that we can look at ctHPV DNA. You can do PCR, polymerase chain reaction, or you can use next generation sequencing. And so currently there are two commercial-based tests that we can now order for your patients. Naveris, which was a test that was developed at UNC, and Sysmex, which is another that was now, again, next generation sequencing based. I think both tests are very good. They're able to have, quantification and help with prognosis for patients. And so why we do Naveris, one is just our familiarity through clinical trials, but it also can detect other strains outside of 16 and 18, so some other high-risk disease strains. Sysmex only does 16 and 18. And so, again, should ctHPV DNA be ordered for all of your HPV-associated patients that you see? It is not standard of care, but I can say this is really being recognized nationally. And if you talk to, head and neck medical oncologists and other providers, many of them are integrating them into the care for their patients. So using it as a baseline to see what the levels of ctHPV DNA are before treatment starts, and then following it prospectively on treatment. And I like to use this test and correlate it with scans for my patients. And I'm happy to answer questions about this. And so finally, what is the data for ctHPV DNA? This was a clinical trial that's done at UNC. And basically what this looked at was recurrence. And so for patients after their treatment was completed, we continued to look in the blood and measure ctHPV DNA. And what we found is that patients that ultimately had positive blood results for ctHPV DNA, they went on to have disease recurrence. And the other powerful thing about measuring ctHPV DNA in the blood is that we're able to detect this earlier in the blood compared to when we found it in the imaging. So there was this kind of lead time of up to 6 months of detecting HPV in the blood before we were able to see it on a CT scan or PET scan. All right, so we just went through a lot of information. Here's my son stretching out. So I want to just everyone to take a quick 10, 15-second break, and then we will move on to the next part of our talk. I think there are some questions. Let me just see if I can answer them too. Yeah, I think Megan Gonzalez asked about next generation sequencing prior to CAR T cell therapy. I definitely think there would be a role for advanced line patients that don't have any standard of care options, where you're looking to see their mutational panel and potentially identifying something in either the DNA or RNA that then we could target either through a clinical trial, doing it off target, or helping to use for something like cellular therapy, like CAR T cell. All right, so now let's go into the research to practice. And so we've talked about the first 3 objectives. And so next we're going to talk about how some of these technologies are being implemented into clinical trials. I really want to touch upon 2 of them: next generation sequencing to determine treatment selection, and then the use of circulating tumor DNA in the minimal residual disease space. And so one slide on NCI Match. This is a trial that's been going on for many years now. And basically what it's doing is having patients, and regardless of what their tumor type is, it doesn't have to be head and neck cancer, and doing DNA sequencing. And so if they find an actionable mutation, then there's multiple arms that patients can go on. And so they have a study agent, for example. This arm is looking at PTEN alterations, and then they have study agents that target PTEN, and then you're able to, follow them. And if they, have disease progression, then there might be another arm of the study that they can go on to. So we've had NCI Match open at UNC, and now there are other kind of what we call basket trials like this that are looking at specific mutations and trying to pair treatments based on the alterations in the DNA. And so TAPER is another study that we just opened at UNC, and would be possible if you have an advanced line patient that we might be able to pair treatments for them. And so next, I really want to spend the time on clinical indications and just talking about circulating tumor DNA, as this is a major research interest of mine. And so ctDNA is powerful in so many ways. One, we can use it to monitor tumor burden to see how well is treatment working. As I talked about earlier in the HPV space, we can use it to predict tumor recurrence. There are now applications to use ctDNA to help select treatment. You can use ctDNA to see how your cancer is evolving over time. Are there certain selection pressures from treatment or other factors that might be leading to drug resistance? You can use ctDNA to say, is this something that is really a somatic mutation, so is it associated with the tumor, or is it germline, so something that was really from kind of a normal non-cancer cells? And then finally, can we use ctDNA to select how we give our patients treatment after surgery. And so what I want to kind of discuss now is the MRD space, or minimal residual disease space. And so what is MRD? It's really the presence of cancer after surgery is completed and where we don't see any evidence of cancer either clinically or radiographically. And here is, in this figure, you can see really you need to have a large volume of tumor to detect it, detected by imaging. And so you can see if you have a smaller tumor burden, it may not be detectable by a CT scan, MRI, or PET scan. And that's really where we talk about the MRD space. And we think that this is where ctDNA can be very powerful. And so rather than having this big group of patients that we think may be cured, but really do have detectable disease in the blood, now we can use ctDNA to really further stratify and identify this patient population that might benefit from additional treatments. And so the whole idea is, can we use ctDNA after surgery to identify those patients with minimal residual disease using ctDNA, and then intervening upon this by giving them some sort of treatment that helps them from going from having, recurrent or metastatic disease to being eventually cured. And that's the hope of and the promise of ctDNA. So first, how has ctDNA been successful to predict disease recurrence? We've talked about it in head and neck cancers, particularly in HPV associated. Here I'm again showing you data in colorectal cancer. And so if you have a patient that does not have detectable ctDNA after treatment, they're much less likely to have disease recurrence. These are two separate studies. And this has been recapitulated in multiple tumor types now, showing that detecting ctDNA, you're more likely to have disease recurrence. And so I did want to touch upon one data that came out at ASCO this past summer. And this was a European study that looked at the detection of ctDNA in patients with head and neck squamous cell carcinoma. And so basically, again, there's a prospective study done at one center. They use both plasma and saliva to detect ctDNA. They had patients including both HPV positive and negative disease, and they followed them for up to 1 year. What you could see is that for the patients that were included, so 45 patients had ctDNA that was measured for the plasma. And prior to getting surgery, in 87%, you could detect it in the blood. And similarly, while the numbers were smaller, there are high rates of detectability prior to surgery in saliva. And these numbers really come down postoperatively, so going from 87% to only 1/4 of patients that had detectable ctDNA after surgery was done. And what was really striking about these findings is that all 11 patients here with positive postoperative ctDNA eventually developed disease recurrence. So it's showing that, again, this is such a powerful test, and that if we're able to identify these patients early and intervene upon them, we might be able to help them have better outcomes. And then, finally, I wanted to end with a study that I'm leading here at UNC. This is Lineberger Comprehensive Cancer Center, 1835. And so, and I talked about this 2 years ago, but this is a study that we are looking at patients with HPV negative head and neck cancer with locally advanced disease who are all getting surgery. And the idea is that, can we measure ctDNA in the blood preoperatively, postoperatively, and then following them along and seeing what the kinetics are over time. And so this is a study that's been delayed because of COVID and some staffing issues, but we are very, very close to opening up. And I think we will be partnering with Natera, which is I mentioned at the very beginning, is a company that basically what they do is they take a piece of a patient's cancer, so say from the surgery, and they do DNA sequencing from that. And after they do DNA sequencing, what they next will do is identify mutations that are specific to that patient's cancer. And then they create a panel that can then be used to measure ctDNA in the blood. And the idea is that, can we use patient-informed and patient-specific panels for ctDNA to really show the evolution of their cancer? So the hope is that, most of these patients will not have detectable ctDNA after their surgery, but if they do, can we see what the kinetics are over time and see how that correlates with disease recurrence? And so, yeah, again, this is kind of what I was alluding to and how we think in the future. And I think this is really in the next 5 to 10 years, can we take a patient that doesn't have detectable disease by imaging after surgery, detected by ctDNA, and intervening upon them so they're finally cured. So in summary, actually, I'll do the summary last. I just want to finish with the clinical cases. So I'm revisiting our 58-year-old patient that I mentioned had original diagnosis in 2020, treated with surgery followed by radiation therapy, and now has evidence of recurrent metastatic head and neck squamous cell carcinoma. So back to the audience, what test is mandatory for patients to have the selected optimal standard of care therapy? Is it HPV status? Is it PD-L1 expression? Is it next generation sequencing? Is it tumor mutational burden, or is it ctDNA? Oops. All right. Perfect. I know some answers are still trickling, but this is opposite of what we saw before. But the right answer is PD-L1 expression and getting the combined positive score. So this patient had already had a previous diagnosis, has recurrent metastatic disease, and so we need the CPS score to determine how to best treat the patient, whether they can get pembrolizumab on their own or they need it in combination with chemotherapy. And so, yes, CPS is the right answer for this question. The next question is, again, so we did all the testing for the patient. We know that they're P16 negative, CPS of 25. They have the TP53 mutation in the tissue and in the blood. So what would be the best treatment option for this patient? Okay, maybe this was easy. Yeah, pembrolizumab is correct. And so, answer D was tricky because nivolumab is FDA approved in head and neck cancer, but it is only in the second line recurrent metastatic setting. And so if this answer said pembrolizumab plus chemotherapy, that would also technically be correct. Just to walk everyone through, cisplatin radiation therapy would be used in the curative setting, but it's not used in the recurrent metastatic setting. A TP53 inhibitor, these are being evaluated in clinical trials, but there's nothing standard of care. And if this patient still has multiple lines of therapy, that would be possible, so hospice wouldn't be approved. So that's why pembrolizumab is a correct answer. All right, so the same patient was treated with pembrolizumab for his first-line disease. He had an excellent disease response for 18 months, and he comes back to you with new abdominal fullness and right-sided pain. You get a CT scan that shows liver metastases, and so he's open to clinical trials and wants to continue checkpoint inhibitors since he did so well on pembrolizumab. From previous next-generation sequencing that his TMB status is low, and he asked if his TMB status is low, does that qualify him for additional immune checkpoint inhibitor therapy? And if so, which one is the right response? No, given low TMB status, you will never benefit from additional checkpoint therapy. No, given your low TMB status and recent progression on pembro, there's no additional standard of care for immune checkpoints available. yes, because you have low TMB, you'll benefit from ipilimumab and nivolumab, or I don't know. I've been on Instagram for the past hour and never really heard of TMB. So we'll let people answer. Okay. All right. So maybe I didn't do a good enough job, but the correct answer is actually B. So, there again, and this is the reason why I don't necessarily recommend um, doing TMB status for our head and neck patients, because they're going to be treated with immunotherapy anyways. And so, and then furthermore, as we talked about, if you have a low TMB status, you're less likely to benefit from immune checkpoints. So that's why answer B is right. And so C, I know the majority, if you put that in, I don't think there's data, and definitely not data in head and neck, that shows that a low TMB status, you would benefit from ipilimumab and nivolumab. And then the other reason why this answer is wrong is that this combination is not standard of care in head and neck cancer. So perhaps a tricky question, but D is the right answer. All right, and then I kind of just didn't put it into the actual slides earlier, but I wanted to show you a study that came out a few years ago that shows that TMB and PD-L1 expression do not perfectly correlate. This is a slide of different malignancies. On the x-axis, you can see median TMB, so 10 being cutoff for high versus low, and then PD-L1 expression, again, higher versus low as you go on the y-axis. And what you can see is that there's not a linear relationship with high PD-L1 expression and TMB. So again, that's why these are imperfect biomarkers, and where one can't be used to exchange for the other. All right, so in summary, there are a number of great and important biomarkers for the management of head and neck cancers. Even in the past 5 years, there's increased clinical utility, so particularly the use of next generation sequencing for advanced line patients, and now this incorporation of ctDNA. These are really kind of the promising biomarkers, and we're going to be seeing them used into more clinical trials. My ongoing studies, I'm using these biomarkers into my therapeutic trials. And so, I think not only within the therapeutic trials, there are also non-therapeutic studies where we're looking to validate ctDNA. So I talked about LCC 1835. And so, the whole goal is to be able to use ctDNA as an actionable clinical decision tool. So not only in the postoperative setting, but maybe in the prior to disease recurrence. And so it is going to be a powerful tool, and something that I think 5 years from now, we're going to just have a ton more of data that will be useful for how we can help our patients. So here's my email address. If you ever want to reach out to me, or if they're a patient that you want to send our way, we'd be happy to see them. Here's our, really phenomenal team at UNC. I just want to thank Dr. Gully, who's been a mentor of mine and really helpful with preparing these slides as well. And so thank you everyone for your time, and I'm happy to take questions.
All right, Dr. Sheth, thank you so much. And I saw a funny comment. Somebody said that was hilarious. You did get at least one response D in that last question, the Instagram one. So. Well, but we'll chalk that up to maybe hitting the wrong button there. So we are ready to take questions, and I'm watching the panel where those will come in. While we're waiting, we were fortunate enough, as you mentioned, to have you 2 years ago on a more in-depth talk, and then this talk now. If we were to have you back in 2 more years, what's on the horizon? What do you think you might be discussing that you're not able to discuss today?
Yeah, I think we're closer to potentially seeing some newer therapies that are going to be approved in the head and neck squamous cell carcinoma space. So that's something I expect. And I think there is just a really a wealth of ongoing clinical trials and biomarker trials that will help us inform how to use these studies further for our patients. And so I do think, you know, the CT HPV DNA, which I mentioned, will get incorporated into guidelines. I know there's a conversation about that happening in the fall. So that might be used even in the community for our patients as well.
Great, great. Thank you so much. And we did have somebody indicate, thank you so much for the info. I enjoyed the webinar. What I'm going to do is I'm going to move ahead a couple of slides and just talk about what's coming up, and then we'll come back to the poll and the question moderation and see if any other questions have been or comments have been submitted. I want to thank the people of North Carolina for their generous support of the UCRF, or University Cancer Research Fund, and the UNC Lineberger Comprehensive Cancer Center. That makes all of this possible, as do Veneranda Obure, John Powell, Oliver Marth, Andrew Dodson, Nadja Brown, and Pat Muscarella for all of their hard work on this and every one of the different lectures in our various series.